This is Dr. Tiwari.
And this is Dr. Kocak.
And you're listening to the
Best Podcast Ever.
Broadcasting from Columbus, Ohio, we'll be talking about plastic surgery procedures focusing on only the breast.
Ranging from breast reconstruction to breast enhancement and reduction, we'll cover everything you ever wanted to know about the breast. All right, welcome to the Best Podcast Ever. This is Dr. Kocak.
Hey guys, Dr. Tiwari. We are super excited today. We're very lucky to have the one, the only, the doctor, the best OBGYN that I know, Dr. Anita Somani here. We're going to talk about a whole bunch of things that range from care of the transgender patient to what's going on in politics nationally and in Columbus. But I
think we should start with the best protein smoothie ever. I really think. And this is not an advertisement, I think, unless you have some stake ownership in one of those.
No stake ownership in this. And honestly, as you all know, I am a big proponent of the idea that food is medicine and that what you eat is how you age and how you look and how healthy you are. And so this is my all-time favorite smoothie. It encompasses everything you need in the morning: caffeine, chocolate, nuts. You can't ask for more. So basically, simple smoothie recipe. If you have one of those little individual blenders or individual smoothies, you can just throw everything in. Basically, half a cup or 4 ounces of your choice of coffee. Sometimes I get crazy and go with flavored stuff. Sometimes I go with regular. 1 scoop of chocolate protein powder. Same amount of unsweetened vanilla almond milk. And then the nut butter of your choice. I'm not a huge peanut butter fan. I like cashew butter and almond butter. And sometimes I'll make my own, almond butter and stuff. So 1 tablespoon of nut butter, blend it, and literally you're having your own dessert in the morning.
So it's a smoothie and it's breakfast, right? You don't even have to have anything else. It's your coffee and your breakfast in one.
It's so funny. We had Dr. Emily Rodenschmeimer on the podcast a couple days ago, and she's a functional medicine doctor who spent a long time talking about food as medicine. So, what is that? We hear those things a lot. What does that mean? How do you communicate that to your patients? What is food as medicine?
How do I communicate that?
Yeah.
So I've been in practice for 27 years. And I've had patients that have been with me through that whole time, literally started with me in their 20s and now they're going into their menopausal years. And over the years, it's funny, they'll say things like, how come you never age? And how come you don't look any different? And how do you maintain your fitness? And literally I talk to them about, and again, this is not a commercial for Whole Foods, but the idea of whole foods being important. I think we tend to overlook things that are basic, fruits and vegetables, the idea of a balanced meal. And honestly, I feel like the pandemic has opened that up to a lot of people. Have you all seen all the bread recipes that the Millennials are making and all the new food posts that are going out there? People are really, really experimenting with cooking. I mean, they're literally going back to the basics. You can't go out. You're not going to go through a drive-through if you're worried about your safety and about how the food is prepared. So you're going to prepare it yourself. So, thinking about planning ahead. I mean, I do a lot of food prep. I do a lot of cutting up vegetables, using my Instapot. Believe it or not, my husband was craving chicken tikka masala, which I've never made at home. But I found some great Instapot recipes and I altered the idea of the restaurant with the heavy cream. I used light coconut milk instead, and it was just as creamy, but less fat, less calories, and, a little bit healthier.
That's so interesting because the Millennials get such a bad rap for, going out to eat and kind of being lazy. And here these guys are, living through the second biggest economic crisis we've had in recent memory. They're dealing with a pandemic, and they're doing all the stuff that, we tell them to do, which is, cook at home, be responsible. So I always think the Millennials get a bad rap.
As a millennial, I appreciate that. Sure, thank you.
Nobody here is a millennial, but Dr. Somani's got a couple millennials in her family.
I do. And honestly, Pankaj, your daughters totally impressed me. They are so aware of what's going on in the world, and they're super smart with their questions. I mean, I think this next generation coming up is going to really impress us. They have a good handle on the world.
One thing that we were talking about before is, how history at some level does kind of repeat itself. And I think a really interesting thing that we hit on was, what is HIV and the response to the HIV crisis? How does that compare to what's happening now? And you had some great insights in it. And I think it's something that is worth talking about because it's not something that I've heard other people talk about.
Yeah. So I was listening, and again, podcasts are amazing. You can listen to them when you're walking. You can listen to them when you're in the car. So I've really taken to listening to different podcasts. And one of the ones that, and the funny thing is I was in medical school when HIV was discovered. And at the time, it wasn't called HIV. It wasn't called AIDS. I mean, there were so many different iterations that it went through. And believe it or not, Dr. Fauci was on the insights or one of the first physicians to really take the lead on that too. And he recognized that, again, the president at the time was Republican and felt that this was a homosexual disease, didn't want to put funding towards it, didn't really want to address it at all. People thought it was a punishment for being gay. There was all this, it's only affecting the gay community. Why do we need to bother with it? Kind of like what we saw with the coronavirus, where people were calling it the China virus. Oh, it's affecting Chinese people. There was even, this don't drink Corona beer, don't eat Chinese food. That's, there's just so much of those misconceptions. And the same thing happened with HIV in the 80s. Lots and lots of misconceptions. And Dr. Fauci was one of the first ones, along with, remember C. Everett Koop, the Surgeon General? History.
Oh, yeah, the guy with the bushy beard and hair.
Yeah. So they started really looking into it. They started running trials. They were kind of on the forefront of recognizing that, no, this wasn't going to infect just a few people here and there, just a certain community. And they came out with a pamphlet on HIV and condom use, and very, very informative, very educational. And apparently the year it was published and distributed, they sent it to every household in America. It was the most read pamphlet. It kind of outread the Reader's Digest, which was the thing to read at the time.
This was probably late 80s?
Mm-hmm. Yep. And they essentially showed, that there shouldn't be any stigma to it. And it passed through Congress because they didn't show anybody what was in it. They kind of were sneaky about it and just said, we have this educational pamphlet, this new disease has come out, and we don't have all the, and I don't know all the details, but basically they got it through Congress. They got it through, passed bipartisan, Reagan signed off on it, and they sent it out. And it was only after the fact that people realized that they did not stigmatize HIV. They did not stigmatize AIDS, and they were very, very medical and very informative about it. And that was also right around the time, if you guys remember, Ryan, I forget his last name, but
sure.
He was the one that became the face of AIDS because he got it through a blood transfusion.
Yeah, Ryan White, I think his name was. He was that young boy.
And that's what finally resulted in funding for HIV research, was putting his face on the idea of AIDS rather than it being something that was just in the gay community. And I think that, unfortunately, we had the same missteps when you think about, my sister is an infectious disease doctor. I had been hearing about coronavirus since January, and that was when the first cases were reported in the United States.
And she's in Singapore, isn't she?
Correct, yeah. And the first cases reported here were basically poo-pooed. It was like, well, we shut down travel to China, so now we don't have to worry about it. That was such a poor response. Like, if we had been prepared, we would have been like South Korea. We would have had far fewer deaths. We would have had far fewer cases. But, there was this whole push to call it the China virus, to stigmatize it, to imply that it was only in certain communities or only certain ways that you could get it. And now we're kind of seeing the backlash from that, and the fact that, 50,000 people have died? I don't even know the numbers anymore, but
yeah, we're about 50. I don't know the exact numbers, but we passed 50,000 a couple of days ago.
Yeah, and we're over 1 million cases in the United States. That didn't need to happen. And I think there's so many parallels in history. And I think that it's amazing that Dr. Fauci's on the forefront of this, but because of politics today, he hasn't been able to make as much of an impact.
I didn't realize Fauci was involved in the HIV pandemic. One thing that I kind of think about is, HIV completely changed the way that we as surgeons think about universal precautions. It sort of changed the processes in the OR, the dynamics. How do you think that Corona is going to do that, not only for us as surgeons, but, for everybody?
Good question. Ergun, what do you think?
Well, I just walked out of the operating room for the first time in about 6 weeks. And like I was telling you guys, they strapped an N95 on my face and put another mask over that. And it's certainly going to, in the immediate future, going to change things. I think for the next few months, we're going to be operating in some pretty uncomfortable ways, I think. And it's very nerve-wracking. I mean, just walking into the hospital was kind of a weird feeling. I haven't set foot in a hospital for at least 4 weeks now. And they meet you at the door and attack you with a temperature monitor and then put a mask on you there. And everything you touch, the mask on your face alone is something that automatically prompts you to touch your face because you're constantly adjusting it. So it's just, and every time you reach up, you're thinking, oh gosh, what have I touched? Got my phone sitting here. I don't want to go near it. I'm scared to touch it until I soak it in bleach or something. So yeah, I think it's going to have, at least in the next few, probably next 3 to 6 months, we'll probably be going through this type of stuff. But I don't know.
We got one of those phone cleaner things for our house, that we have at that one place.
The UV things,
so,
yeah,
the UV thing. So I pop my phone in whenever I come home.
That's that's interesting.
I don't know if it does anything, but.
So the interesting thing is, Ergun, I have been going to the hospital consistently since this all started. Just because, as you know, babies didn't stop being born during the pandemic. They're still coming. They have no idea they're coming into a pandemic, but they are. They're being born. And I've seen sort of
how irresponsible of them.
Yes, totally. But it also has created that sort of joy in a moment of uncertainty and scariness and everything else, to see families. So the transition has been really interesting. When the pandemic first hit, there were no special entrances that you had to go in and out of. We just kind of walked in like we always did through the back door and went up to labor and delivery, and nobody was wearing masks, and you kind of had the impression that nothing had really changed. And then over the next kind of few weeks, they started making visitors get temperature checked, and they only could go in a certain entrance, and employees were still sort of do whatever you want to. And Starbucks was still open in the hospital, and the cafeteria was still open. And the next thing you know, they're shutting those down, and they're, putting it even in the doctor's lounge, the food was now all boxed and individualized, and you didn't touch anything. And over the last couple weeks is when they started doing what you went through, where you had to have, and at first it was temperature charting with your forehead. And every time I would walk in, I'd walk in from the cold, and I was like, this makes no sense. I mean, my temperature is 95, it's 96. It's like, how is this realistic? And then they started doing wrist checking without touching you. It's sort of like just kind of waves over your wrist, and started handing them masks. And at first I was wearing my own mask and then they started giving you a mask. And then you started noticing everybody was wearing masks. And the thing I noticed the most, though, was how quiet the hospital became over the last the last 6 weeks, because no visitors were allowed. Our pregnant patients were only allowed one support person, and that support person had to stay with them in the hospital. They couldn't come and go. They didn't want, the person coming in and going home. So I literally had a FaceTime delivery on Monday. My poor patient, her dad died within the last month. So her mom, was really having a hard time and just didn't feel like she wanted to drive down and spend a couple weeks here and then, be there for the newborn. And I think this is another thing the pandemic has helped, is people are starting to get to know their neighbors. But she was like, I really don't know anybody that I want to leave my kids with. And so I think, and it was her third baby. And she's like, I think I'm just going to come and have the baby by myself, and then my husband can pick me up. And I'm like, are you sure? That I just felt, it just broke my heart, And I said, well, I remember one time I had a patient whose husband was in the military, and we just FaceTimed, and like he felt like he was a part of the process. So she ended up FaceTiming with her husband, and the girls, they're a little older. They're like 5 and 3. And so when the baby was born, they got to see the baby on the screen, and, got to see him right away and stuff. And so, I mean, her husband was really grateful in that respect, but it just felt odd. It just didn't feel right.
It's such a change. I mean, like we were talking about, we converted all of our clinics to these virtual consults, right? Where we have some photographic stuff and we're able to talk to the patient over the phone or virtually. And the question came up, when do we go back to just filling our clinic days, with consults all day? And, after we talked about it a bit, I don't think we ever need to go back to filling our whole day with, direct patient interaction. I mean, at some level, this type of format now is going to, in some way, I think, stay forever once we figured out we don't have to be doing some of the stuff we were doing before. My son is taking a virtual lesson for what stringed instrument, right? And because they can't do them directly. And I guess the place that does the lessons, we asked them the question, will this be offered? Because they're far away. Will this be offered? Is this now going to be permanent once things go back to quote normal? And apparently the owner said, well, the genie's out of the bottle now, so can't put it back in. I think it's going to permanently change, not just how we do things, but how a lot of businesses probably do some stuff. I think it's going to always be a little different.
Yeah, I think it's definitely accelerated trends that we were starting to see. I mean, we talked about doing telehealth consults for a while, and this kind of really pushed it, that it's become an option. I think patients want that option. I think now that they see that it works and it's a reasonable way to do things, I don't know if we're going to go back to it. I think it's convenient for people just to be able to talk to their doctor from their house.
Yeah, I agree. I mean, I think, like you said, the genie's out of the bottle, and the fact that because it was under duress, that we were able to get payments that are equivalent. And we've already started seeing our payments are coming in and they're equivalent to office visits. It's going to be hard for insurance companies to backtrack and say, no, we're not going to pay for telemedicine. I think it really helps the fact that when you think about access in areas like the rural areas of Ohio, where there's so little access to care. I mean, we see a lot of referrals for robotic surgery from these, rural areas outside of Ohio. And it would be so easy to do a telemedicine consult with them and then just have them come up and do the pre-op visit and the surgery here, but not have to come up here 2 or 3 times to meet us before surgery. I mean, I do think that it improves your access in areas where there is so limited access to care.
Well, if you're doing robotic, can't you just do it from your living room anyways?
Sure. You just put the robot wherever. It's fine. As long as I have the console, I'm good.
Yeah. I mean, can't they just drop one in? Technically speaking, I mean, you just need the people in the OR to get the stuff in there, right?
Exactly.
Yeah. So
now, do you know the history of how robotics started?
I mean, I remember that there was talk about being able to have advanced surgeons do surgery across the country in the military setting. But do tell us, give us the real story.
Well, you have the real story. So this was originally a development for the military, because when you looked at outcomes for soldiers, their outcomes were best if they were operated on as soon as possible after the injury. But most of the military hospitals aren't close to the front lines. And so that transfer of getting the soldier to the military hospital took time. And what they found was if the surgeon could be at the hospital directing and operating the robot, and the people on the field, the medics on the field, could just set up the instruments for the soldier to have surgery, it made more sense. And so that's kind of how it started. But again, that's such a limited application that Intuitive then said, well, what else can we do? So that's how it started. The first specialty that was approved was urology, and then GYN oncology, and then general GYN. So we started doing robotics in 2009, which was sort of that first wave of general GYNs getting trained to do it. But you're right. I mean, literally, if everybody had the console in their home and somebody else could attach the robot to the trocars and do all that, then there'd be no need to be in the operating room.
Our radiology colleagues are all sitting there saying, I don't know what you're talking about. We've been doing this for years, right?
Yeah.
So my daughter showed me this YouTube video this morning of her, like her favorite YouTuber, some engineer, who set up a VR hand control with a kitchen knife attached to a robot arm. And the kid was able to control the kitchen knife with the robot arm. And it was a bit of a gag, he was operating on a dummy. But that's a pretty sophisticated setup for somebody to do in their house.
Yeah.
And probably is VR going to take over robotic surgery? So you're not in the console, you're sort of controlling things without even a console?
There have been different companies are looking at different iterations for the robot. I mean, nothing compares right now to Intuitive's, to the Da Vinci that we use. But there's certainly, that's what engineers are for, right? They come up with these great ideas and figure out how to actually make them work.
Now, you do a lot of transgender surgery, hysterectomies for transgender patients. Is that a robotic surgery? Is that an open surgery?
It's robotic, which is partly why we've gotten a lot of referrals for it, because their downtime, and I hate to, badmouth you guys, but a lot of those patients will tell us that their robotic hysterectomy was an easier recovery than their breast mastectomy,
Oh,
for sure. Robotic surgery is pretty minimally invasive. What we do is not that minimally invasive.
That's it. Yeah. We're going to figure it out. We're going to make it robotic.
Yeah. They refer to it as top surgery. They're basically like, oh my God, this was so much easier than my top surgery. But I think one of the big things with transgender care is being sensitive to those patients' needs. We don't do the hormonal therapy for that. By the time we see those patients, they've already made a decision of, what is comfortable for them, what they feel they are. Our feeling is we want to complement what they want, what they believe they are. So when we do the hysterectomy, one of the things that ACOG talks about is making sure they understand the ramifications and the differences between the removal of the uterus versus removing the ovaries also. So when you think about it, we don't really think about the fact that we all have kids or how we had kids, right? It's kind of a given. You have sex, you get pregnant, you have a baby. But there's a lot of other ways to have a baby. And oftentimes, when you're looking at someone who is transitioning, they may feel very strongly that they want kids or they don't want kids. And those are things that we need to address with them. So, we always talk about the idea of if we leave the ovaries, you still have the option to have a surrogate carry your genetic child, because they can harvest your eggs and they can, fertilize the egg and then allow for someone else to carry your genetic child. So,
does that interfere with their hormone therapy in any way, or does it change it in any way?
It would. Yeah, they would have to definitely have ovarian stimulation during that time. So, and there's a lot of layers to that, but I always want to make sure that I'm addressing the whole person. So, I always give that as an option. No one's ever taken me up on it, but I want them to know. And as ACOG recommends, you want to talk about that. You also want to talk about it in the context of the ovaries provide a lot of support for your heart and for your bones. So when we put women through a surgical menopause, we are also affecting their long-term morbidity and mortality. And so guidelines have changed in terms of removal of the ovaries. The suggestion now is to leave the ovaries up to age 65 and remove the tubes, which reduces your risk for ovarian cancer by about 60%. So even though the ovaries are still there, they still have that risk reduction because we removed the tubes with the uterus. So going back to like the transgender patient, they're taking testosterone, which obviously helps your bones, but testosterone can have a negative impact on your heart. So the overall benefits of and risks of removing the ovaries need to be discussed when you're going through the preoperative evaluation, when you're talking about it, when you're counseling. The other big advantage to the robotics is we can send those patients home the same day. And I think that, we're all very sensitive to how we care for those patients, but not everybody is. And one of the things we ran into when we first started doing transgender surgery was our patients typically go to the OBGYN floor. Well, that floor also has new moms on it, and the nursery is on it. And, so the nurses that are caring for our patients that had surgeries we're also caring for new moms. Now you put a patient who's just had a hysterectomy, a trans female or a trans male, and you put them on a OBGYN floor. That's very awkward. And so then we were faced with where do we put these patients after surgery? And we ended up having them go to the urology floor. But that was also awkward because those nurses weren't used to getting our patients up moving around. And in order to get our patients out the door quickly, we need them to be eating. We need them to be up moving around. We really want to encourage them to get out within 24 hours. And so luckily, Riverside just opened what's called a short stay unit, which we've been using, and it's wonderful. It's for all of the minimally invasive procedures. The nurses there are very sensitive to our patients' needs, and they understand, and the patients aren't put in an awkward position of being on an OB floor when they've just gone through a surgery, where they're completing their transition to becoming male. So I think, it's like everything else. You live and learn, and as you do things, you recognize, I'm sorry, I did that to that patient, in terms of being part of that learning process. But
it's interesting though, this, as you bring up a good point. In our practice, we're growing the component of transgender surgery, and we're, gender reassignment surgery, especially top surgery, like you brought up. And as part of that, we kind of recognized that was going to be a very important piece, because we've functioned sort of in one space for a long time in the breast reconstruction arena. And we were lucky to find a group, Equitas, here in town, actually offers some very good educational programs. It's actually extensive. They'll come into the office through a program. They call it a structural, structural competency assessment. And they'll go through everything from like the signs on the doors to the paperwork to how things look in your EMR. I mean, it's a pretty extensive evaluation and restructuring of the practice in order to make it, like you said, friendly in that way, so that it's not, so that you don't have things that are missed or not considered.
Yeah, that's one of the biggest problems with EMR though. Epic, because, when you're doing the exam, I'm still examining them when they have their uterus, tubes, and ovaries. And, and so we have to put in the female component of the physical exam, but we understand that they want to be addressed as he or him, and so if you pick the male version of Epic, when you put the patient in, you get the male physical exam, and it's very,
so it hasn't undergone a structural competency assessment at this point.
Yeah, but I have no doubt that as you're building a program at Riverside, and as transgender surgery becomes more of an option for patients, EMRs will no doubt follow along. But I think the key is recognizing that there's a need in the community, and it seems like there is in Columbus from us talking to you and some other folks. Are your patients coming from all over Ohio or all over the country?
So most of our patients have come from referrals from physicians that are doing the hormonal therapy and the support that comes prior to actually coming in for surgery. Right now, I would say mostly Central Ohio, but certainly as we move, more and more into just doing GYN and robotics, we'll expand our reach. We haven't yet, but I do know, talking to the physicians who do the hormone therapy, that they do see patients. And that also brings back the idea of telemedicine. When you're consulting or you're doing the hormonal, assessments for those patients, and they're coming from all over, whether it's just the Midwest, this sort of tri-state area, it would be a lot easier to do it as telemedicine. And once you've gotten them on their hormone regimen and they're comfortable with it, rather than having them come into the office every few months, because testosterone is considered what is that with the DA, the different classifications, like a
schedule 1, schedule 3. Is it 2 or 3?
Mm-hmm. I think it's 3.
Okay.
And you literally can only prescribe it for a certain period of time, and because we use testosterone sometimes for our women for libido issues, and again they have to come back in and they have to be reevaluated. They can't get the prescription for a full year. So I think that coming back full circle to our original discussion about telemedicine, it just lends itself to so many areas.
Yeah, it's interesting because I think we're seeing the same. Our breast cancer reconstruction patients come from all over, and we've seen this now also with our patients who've had problems with implants. They sort of find us, we talk to them through telemedicine, and then we'll operate on them without necessarily having seen them or having them make a trip to Columbus. And I think the transgender patients are going to be similar. That's our feeling. So I think your point about telehealth is well taken. Something else I want to touch on is you're very involved in the Columbus, the Ohio kind of medical political community. You're the president of the CMA. Give us an update. What's going on right now that our listeners need to know about the state of politics in Columbus through Anita Somani?
Pankaj, you give me far more credit. I'm actually the past president, but certainly one of the biggest things that I think that Central Ohio did, which is really impressive, is that all of our hospital systems worked for years. It's called Central Ohio Trauma Service. And the idea has been that if there's a mass catastrophe in Central Ohio, how do you triage patients? How do you get them to the right hospital for the right care? So this has been something they've been practicing over and over again over the years. But what was really exciting and what was different is that when this pandemic came about, all three systems, Ohio State, Mount Carmel, Ohio Health, they all got together with Bob Falcone, who's the CEO of the CMA, and they came up with a plan where the convention center would be used as the sort of step down for people who didn't need hospital care but still needed care. And they all worked together to create, and I think you guys all saw they did the news stories on it, and they had pictures of how it would look in terms of the beds and the care, and it looked like, MASH 1950 with the partitions and, all the whole convention center broken up into little pods basically for patient care. And I think that was very unique in terms of how they were able to be proactive and manage to create a unified response. Now, fortunately, if you remember, prior to all this, we kind of started flattening the curve in early March when they canceled. Well, they didn't cancel the Arnold, but they made it so it was all virtual. I remember being in the OR on that Friday, and our friends who were participating in CrossFit, some of the staff, they're watching it on their on their phones. They're watching the athletes competing because they had essentially canceled. There were going to be no spectators. They canceled the events that were the big venues where all the vendors come and sell their products and stuff. They canceled all of that. And so
that was a huge call by DeWine. Very, very gutsy.
Trust me, I heard all about it because I'm good friends with the ID docs, one of the ID docs. And that week they were having phone calls, and the mayor and a lot of the business people were like, you can't do this. You can't cancel it. It's going to really hurt the economy. This brings in millions of dollars to Central, well, probably more than that, but it was a really, really gutsy call. But I think that forward thinking has paid off, right? We've been lucky. Central Ohio didn't have nearly the cases that Cuyahoga County did. We had far less than would have been expected for our size city.
Yeah. And for people that don't know, the Arnold Classic is a sort of sports athletic bodybuilding competition based in Ohio after Arnold Schwarzenegger. It's a really big deal. So canceling that was for me kind of like, wow, we're taking this really, really seriously, as we should be.
And it was devastating for me. It was a big one.
Do you go to it every year?
I've gone a few years. I lived in that world for a little while, at least pretended to, and it was fun. It's an exciting, it's just a really fun event. One year I went with one of our hand surgery colleagues, and he was nice enough to make me his guest.
Yeah, I know who you're talking about.
And he brought a pistol grip, a measuring device to measure grip strength. And he walked around the vendor hall with me, and I didn't know this was going to happen. And so, me being with a little bit of scientific background, I think he wanted to run a quick experiment to see if he had better grip strength than really big bodybuilders. And surprisingly, he did. He actually outgripped most of them, but I think most of them were taken by surprise. They didn't know how to do it. And he would win, and then he'd go, ha!
He's like that. You ever see those videos of that little lady that walks around the Arnold telling bodybuilders that they're soft?
That's it. It was exactly that. I thought we were going to beat up, but it was a lot of fun.
So, Ergen, are you like that baseball player who secretly competes in another sport?
No, I don't secretly anything. Trust me. I try to do a lot of things, and I have over many years established very clearly that I think only do one thing well, and it is like surgery, and that's it. I think that's the only thing I'll ever be good at. That's okay. I'll take it.
Well, I tried my hand at making bread. I made focaccia last night.
So this seems to be the rage, at least on social media. Everyone's posting some. I think sourdough might be the ultimate challenge. Is that true, or are they all pretty difficult?
Well, I have a starter. I was given a starter by a friend's son, one of those millennials who's been making sourdough that when you look at his pictures, looks like it's coming from San Francisco, that it is the ultimate professional sourdough. So he gave me the starter, and I'm reading the directions on it, and I'm thinking, this is harder than surgery. I'm not sure that I'm going to actually do this. Because it's literally, you have to feed the starter every week. You have to make sure it's the right temperature. Then you have to let it sit out before you use it. There's a lot to it.
So this is in the absence of like a simple old little bread maker, like the stuff I'm used to. You just pour the stuff in and hit the button.
Oh, no.
This is different.
This involves that hand strength you were talking about. You're kneading the dough. You're working it. And maybe that helps. Maybe that gets your frustrations out,
Wow, I'm pretty sure I would not be good at this, so I'm going to pass on the bread making. It sounds...
Well, the focaccia was a no-knead dough recipe, so I did not have to knead it. And
How did it turn
out?
It actually turned out really good. One thing I did learn, in case you guys out there want to try making focaccia, if you put toppings on it, which I put sun-dried tomatoes and fresh garlic on one of them, I didn't push it into the dough far enough. So as it baked, they kind of fell off. So it didn't come out a sun-dried tomato garlic. The other one I did with the fresh garlic and rosemary and herbs and some sea salt. And that one, luckily the toppings stayed on the bread itself. So I'll send you a picture. I'll text you.
You just have to put it in social media, right? It has to go up.
We'll put it on a link to the podcast.
And we'll be sure that any of our listeners who want the instructions and recipe will just reach straight out to you.
That one actually came from the Washington Post. All they have to do is type in Washington Post, no knead dough, and it makes enough dough to make. And then they also have links to all these different recipes. That same dough you can make cinnamon rolls with, you can make pizza with, and you can make the focaccia with. So it's multi-purpose. I'm
sitting here trying to type out the topics that we've covered in the last 40 minutes or so. And wow, this is going to be an interesting one to have a little description for.
Yeah, hashtag COVID-19, hashtag focaccia, hashtag Arnold Classic.
Hashtag robots.
Yes,
robots.
robotic surgery. Oh my gosh.
Hashtag protein smoothies. Hashtag.
There you go.
I got that one. And then we've got the Arnold Classic.
Yeah. I mean, I think a lot of it could be covered under how to entertain yourself during a pandemic,
I think, and in there, we've sprinkled in a few decent medical topics that I think are going to be pretty useful. I think I'm pretty excited about this whole gender reassignment program that's growing in the, at least, through your efforts and on the Ohio Health side. And so we're excited to be, involved with this as it starts to grow. And so hopefully we'll be able to see it turn into something that helps patients, prevent them from traveling far away for these operations. It'd be nice to be able to build something here in Central Ohio that would keep the patients closer to home.
And, it would be so nice to have that seamless care. I think that oftentimes what I hear from these patients and, from patients that come from all over for robotic surgery is, oh my gosh, it is so nice, just to be treated compassionately and to know that, as a patient who maybe oftentimes has been maybe just not connected with the medical system, oftentimes doctors bring in their own prejudices and their own biases. And to have that, we've trained our office staff, in terms of treating every patient, with the care and the sensitivity they deserve. But these patients deserve even more of that in terms of being respectful of what they're going through, being respectful of how they want to be addressed, being respectful of their needs, and to be able to offer that seamless care where I could say, you know what, we have some great plastic surgeons, they can do your top surgery and we can help with this. And you already have a great doctor doing your hormonal support. I think it gives them a better experience. It gives them more trust in the healthcare system. I'm glad you guys are doing this. It's really nice.
Well, thanks so much for, joining us on our podcast. I think that's a wrap for us. And, this has been probably my favorite podcast because we covered so much. So hopefully we can have you back.
Can I throw one thing out there?
Yeah. Please. Where can people find you and stuff?
I was a virgin to podcasts, so this is exciting. This is my first experience.
Ooh. Well,
natural.
Yeah, you knocked it out of the park. We're gonna have to make you a regular.
It would be fun. It's been fun talking to both of you.
Thanks, Anita.
Thanks. All right, guys, stay safe.
Take care. Bye-bye.
Bye-bye.
Thanks for listening.
We hope you found this episode helpful.
Want more info? Connect with us at mwbreast.com.
And go behind the scenes with us on Instagram at mwbreast. Thanks for tuning in.
And join us next week.